Welcome, everyone, to today's virtual policy forum, Telehealth After the Pandemic, Perils, Promise, and Possibility. We're so glad you could join us for this timely conversation. I'm Murray Ross, a Vice President with Kaiser Permanente, where I lead the Kaiser Permanente Institute for Health Policy. At the Institute, we host events and publish information to shape policy and practice on important health topics. We often convene experts to share knowledge, spark conversation, advance our collective thinking, and explore opportunities to cultivate healthy communities and promote accessible, high-quality care. I'm very interested in the innovations shaping the future of healthcare, and I'm pleased to facilitate today's conversation with leaders working to shape that future in the telehealth space. A few housekeeping points. After some introductory remarks from our speakers and a moderated conversation, we'll take questions from the audience. You can submit questions through the Ask a Question box on your screen at any point during the forum. If you're on a large screen, it'll be to the right of the main window. On a smaller screen, it'll be right below. We'll also pull questions from those that were submitted during registration before the event. We probably won't have time to get to every question, but we'll do our best to ask as many as possible and answer them. If at any point you experience technical difficulties, please submit a question to the host through the Ask a Question box. This event is being recorded, and the video will be made available on the Institute for Health Policy's website in the next couple of weeks. Now on to our content for today. In this conversation, we'll be discussing telehealth and where we may be headed in the coming years. But before we jump into the future, let's pause for a moment to think about the recent past. I can remember when almost no providers were offering telehealth. And I remember more than a decade ago when our leaders here at Kaiser Permanente saw that electronic medical records and telehealth would be an important part of our healthcare future, and our organization invested very deeply, very early in these areas. As an integrated system, we were able to move significant resources to realize that vision, and we continue updating and expanding our telehealth coverage. I'll pause here to show a slide that illustrates how telehealth use within our system has been changing over time. And we'll share an infographic with some additional information about Kaiser Permanente's experiences this past year. Now, if you look at the slide, which I'm hoping is up there since I can't see it, you can see that for many years now, use of telehealth has been steadily increasing. We started 2012 at the bottom with 93 million outpatient touches to 2020 with 152 million outpatient touches. You can also see in 2020 how office visits, which show up in the dark blue, declined dramatically and were replaced with telephone and secure email visits. Luckily for us, we were ready for that shift, and when the pandemic hit, but many others across the healthcare system had to build whole new telehealth capacities or scale their capacities very quickly. According to a study by McKinsey, health systems reported 50 to 175 times the number of telehealth visits compared to before COVID. So for some framing on what telehealth can include and some of the benefits, let's see a short video.
We hear a lot about telehealth, but what exactly is it? It can be a thorough doctor or specialist visit by phone or video. It can include chat and text from your healthcare team and the ability to send secure messages to your doctor. It can even be remote monitoring of chronic conditions or online physical therapy appointments. And it has benefits that both patients and providers like.
What I really like about it is the convenience. Being able to sit in my own home and have a visit with her is great.
The beauty of a telehealth visit is it really meets the member's needs, where they want the care, when they want it, how they want it.
Having a doctor in my phone, in my pocket, was really great. He had all my information ready, and that made the visit go really quickly.
Patients use our remote monitoring programs to send us information like blood pressures and blood sugars that input into the electronic medical record. When you capture the information in real time, you are set up to deliver high-quality care.
We're still able to form connections utilizing these different ways of connecting with patients. It has made it so much easier for patients to get the care they need.
Telehealth can be beneficial. Every day, it's evolving. But people are asking, is telehealth designed for and accessible to everyone who wants to use it? Does it provide high-quality care? Does it meet patient needs? The answers to these questions and others will determine the future of telehealth and the future of care.
Sorry, I'm now unmuted. I was saying, so telehealth can be beneficial, but there are also risks, and we're going to dig into that complexity today. We'll have a group conversation about these issues with all three of our speakers after some opening remarks from each of them. To set the stage and provide more background on the current state of telehealth, Dr. Reed Tuckson was scheduled to join us, but had a last-minute family emergency this morning. We're thinking of him and sending good wishes to him and his family. He was gracious enough to connect us to Dr. Richard Bakalar to speak in his place. And Dr. Bakalar, we're so appreciative that you were able to join us on such short notice today. Dr. Bakalar has over 35 years of clinical, telehealth, medical informatics, and healthcare executive leadership experience. He was board certified in internal medicine and nuclear medicine while serving in the US Navy. Currently at ViTel Net, Richard advises the CEO and leadership team on strategy for solution design and clinical integration, and he assists clients on adopting telehealth services across healthcare settings, enabled by the company's collaboration platform and medical imaging cloud. Previously, he was a U.S. physician consultant in KPMG's Global Healthcare Center of Excellence and the healthcare advisory practice leader for virtual care in the U.S. and internationally. He also worked at Microsoft as a physician executive responsible for provider communications and clinical case development, and at IBM as a chief medical officer on their healthcare solutions team. He is a past president of the American Telemedicine Association and formerly served in the medical corps of the U.S. Navy, working as the Navy Surgeon General's first special assistant for telemedicine. A very rich and relevant background. So Dr. Bakalar, I will turn it over to you.
Thank you, Murray. I really appreciate the opportunity to speak with your audience today. And as was mentioned, I've got over 25 years experience in telehealth. Kaiser Permanente obviously has got quite a bit of experience, probably a similar amount of time and background, and has been able to make the transition very well. But the majority of the country wasn't so well prepared for the COVID-19 pandemic last year. And so to level set a little bit, I wanted to provide kind of a framework to think about the technology that most of us think about when we think about telehealth. Unfortunately, most people think about what we're using today, the video conferencing component of telehealth, which is important but not sufficient to really provide the services that we really want to provide our patients. But above the services of video conferencing, there's point solutions, which adds some workflows, but usually around a specific use case. And those can be very helpful for very limited use of telehealth in very isolated cases, for example, home telehealth, remote patient monitoring, et cetera. But for organizations like Kaiser Permanente and other large health systems that want to use more comprehensive telehealth solutions, they need what we call an enterprise platform. And I'll describe that here in a moment. And then on top of that, some organizations provide not only the technology, but also the clinical services when organizations don't have them inside. And so this provides kind of a framework of which you can think about telehealth. And where we're moving from is from isolated applications towards platforms. And I'll describe that why in a few moments. Next slide, please. This kind of describes the ecosystem of telehealth. And you'll notice at the bottom, the EHR, the PACS systems, the partner EHR systems, those all represent the systems of record for organizations for the traditional face-to-face care that we often provide our patients. In the telehealth world, we need to integrate that with the telehealth services. And telehealth cloud services on a platform can provide things like collaboration like we're doing today, but also language interpreters for those who don't speak English or have limited English capabilities, documentation, workflows, imaging, scheduling, and performance reporting. All of those services can be done on an enterprise basis and then having specific use cases around different care settings around the country. So what's the current state of telehealth? Well, the idea I think we want to think about is where were we before COVID hit? And you can remove the slides at this point. I wanted to just highlight some of the changes that occurred last year. Before the COVID pandemic, organizations had very limited use of telehealth, usually in the 1% to 2% cases of their total volume. They typically were departmentally based. They typically had fragmented workflows, fragmented data silos. There was provider-to-provider applications, there were direct-to-consumer applications, and then there were remote patient monitoring, all of which were separate and siloed. Many organizations didn't even count their telehealth services because they would represent such a small amount of the services they provided, and therefore didn't code them properly and didn't often use them in their data warehouses. And also the projects for these were developed, again, within departments and not at an enterprise level. Well, that all changed overnight, literally about 18 months ago, right after the pandemic started. And one of the things we learned very quickly was that many organizations weren't prepared. They started implementing video conferencing. When they tried that, they found that they couldn't because they didn't have webcams, they didn't have mobile devices, they didn't have infrastructure in place, they didn't have training, and the providers didn't know how to use it on a large scale. And the scale we're talking about is going from 5% to up to 80% in some cases. So the use of telehealth had to resort back to just using teleconferences as opposed to video conferences. And that, in my mind, is not really truly the opportunity around telehealth, where you don't have the integrated solutions around the traditional care. So the ability to be able to transition from one care setting to another, from face-to-face care to over to remote care, is something that's going to happen over the next year or two. And so, as we learned last year, the government invested in what we called the National Emergency Telecritical Care Network, which was an opportunity to provide critical care not only in the hospital, where in ICU settings or in the med-surg wards, but also at home. And one of the lessons learned from that project, and our company was privileged to be able to support that project, learned that some of the patients at home were using home oxygen and were fairly ill, because there wasn't access to hospitals. And so the ability to use a platform remotely was very important to be able to provide patients care when it wasn't available at a hospital or it was too unsafe to move to a hospital. Also, patients who had to leave the hospital early were able to be monitored remotely and making sure that they didn't regress into their prior state. And so the ability to use the platforms and the services around telehealth can be very important during disasters or critical care settings, such as what we experienced last year, even if it's on a regional basis or a limited basis, as we typically see in hurricanes or earthquakes and things of that nature. So where do we go from here? Telehealth is going to be in transition, as I mentioned, and one of the things we're going to look at are the 4 different areas, the framework as I describe it, where things are going to change as the national declarations of emergency and regional declarations expire. We're going to be regressing to the old way of doing business, which is not necessarily conducive to promoting telehealth on a scale that Kaiser has been experiencing over the last many years, as was described earlier. So reimbursement, regulatory policy, technology standardization and simplification, and clinical governance is all going to be an important part of this transformation that's going to occur over the next year as we regress from a crisis status to a more routine status of healthcare. And so, for example, in reimbursement, moving from fee-for-service that is more open to telehealth that allows for new originating sites and allows for additional providers to provide those services is going to be important. But even more important in the longer term around reimbursement, we're going to be looking towards value-based care, where we can have better alignment with telehealth with respect to integrated care, not just isolated remote care or face-to-face care, but integrated where it makes sense. And bundled payments and so forth will help promote those kind of solutions. From a regulatory perspective, licensure, medical credentialing, and privileging is going to be important. We have to simplify that on a cross-state basis in order to use this on a scale that we've seen over the last year, or even at a lower scale, but higher than what had been pre-pandemic. From a technology perspective, we want to be looking at how infrastructure can be simplified so that we don't have many, many applications trying to do overlapping functions, where we can have a single platform that can provide remote care and link that to our electronic health records, our financial systems, our data warehouses, so we can have integrated care across the continuum as an enterprise level, and having enterprise governance to provide standard operating procedures, and having more standardized protocols where organizations can train and exercise telehealth services on a routine basis. So the idea of providing centralized management and leadership control over telehealth will go a long way in allowing us to grow and scale what we experienced last year in a much more productive way and a much more consistent way that's sustainable going into the future.
Thank you, Dr. Bakalar. That's a really helpful framing. Now let's see a short video highlighting some perspectives Kaiser Permanente members have shared about what they want from telehealth.
Telehealth is increasingly used as a safe, effective, and convenient way to receive medical care. But there's still work to do to meet patient and provider needs. Patients want their telehealth experience to be just as good as their in-person experience.
A virtual visit should feel the same as a physical visit. You should be getting the same results.
They want telehealth to be seamlessly integrated into their total care experience.
Integrate telehealth interactions into the rest of my care. Include past calls, emails, and recommendations into my health records.
They want equitable telehealth access.
My internet is too slow.
An easy-to-use technology platform with options for translation or meetings in native languages.
And they want their health information to be secure and private.
A trusted and secure connection to the service, knowing that my communication will be completely private.
So clearly getting telehealth right is not easy, and there's lots to address. So as we shift our discussion about what should happen in telehealth, we'll hear from two speakers who will provide some brief opening remarks. First up is Dr. Tad Funahashi, who I've known for many, many years, and I'm always fascinated to hear about what he's working on. As Chief Innovation Officer for Kaiser Permanente at the Kaiser Permanente Innovation Studio, he leads a team of physicians, consultants, designers, data scientists, and engineers working with teams across Kaiser Permanente to envision and build the healthcare delivery system of the future. They focus on enhancing member experience, leveraging big data to improve care, and exploring other new opportunities. He's also a practicing orthopedic surgeon with the Southern California Permanente Medical Group. Dr. Funahashi, I'll turn it to you now.
Great, thank you, Murray, and thank you for all of those that are joining us online today, and hope we have a good and robust discussion. Richard, thanks for framing that telehealth landscape very well, and let me add on to his comments by talking a bit about what we've been working on at Kaiser Permanente. So if you just take a step back and you say, why telehealth, right? There always has to be a why for our consumers. And in terms of why telehealth, really what it does is offers convenience and ease and perhaps even lower costs in a much more convenient manner as a consumer. And if you think about just about every other experience that you have as a consumer, and now healthcare is a little bit different, mind you, but generally speaking as a consumer, think about the transformation of your banking, your travel, and of course, your products and purchasing, how dramatically it's changed over the course of the last 4 or 5 years. And yet, think about your healthcare experience. It's still fairly arcane in the way we do it. It's been the same, and I have to admit, it's been very convenient for us from a physician viewpoint, right? But if you said, as a consumer, I would like a product when I need it right away because it's urgent, that I have to call to make an appointment. And then I have to go there, park, wait in the waiting room for a period of time, and then put on clothes that you may or may not be really happy to put on that we choose for you, and then sit on our paper napkin for a period of time for us to bring you that product at that moment at our convenience. You would say, you know, there has to be a better way to provide that product for me, especially in today's world where every other aspect of my life is so much more convenient and easy and based towards personalized, individualized experiences for me. So we've been thinking about this for quite a period of time within Kaiser Permanente, and I want to share with you some of the framework of the way we've been thinking about this. Next slide, please. One of the ways to think about it is, what are the various segments of consumer experiences that people need to have in healthcare? And we can break up those in, of course, virtual and big data. We'll concentrate obviously on virtual today. But at Kaiser Permanente, we've long really pushed prevention and health, population health. And in order to do that better, Are there ways that we could do this better through telehealth than waiting for you to come and see us? And the opportunity, no doubt, is yes. We'll talk about some examples if we get a chance during the discussion. The bulk of the care that people receive is in the cohort of ambulatory care. This is your urgent care, your emergency room, your primary care, your specialty services, and whatnot. And in that arena, about 80, 90% of the care we provide, are there opportunities to dramatically transform and improve the ease and convenience and the quality of that care? And the answer to that is no doubt yes. And we'll talk a bit more about some of those examples in a second after I get finished with the framing. And of course, nobody wakes up in the morning and says, you know, I think today I would like to end up in a hospital as a destination to go to. And yet, sometimes you have to go. But what if, rather than ending up in a hospital, if you needed that acute level of integrated, coordinated care, we could provide much of that for you in your own home? Would that be more comfortable? Could that be better care? And in fact, would that be overall a better healthcare system for you as consumers of healthcare? And I think the answer to that is also yes. So we'll talk about some examples in that. And then in the burgeoning area of chronic disease management, again, in chronic disease management, if you think about the, so to speak, the management of that disease, most of that management actually does not happen in my office or Richard's office. It actually happens where you live, play, and work. And yet, we think that by having you come in for that moment in time with us, that we can better manage your chronic disease. And actually, it's probably wrong. In fact, the chronic diseases could most likely be better managed in your setting by us reaching into your homes where you play, you work, and whatnot, and then watching you with your social networks there, watching you with your nutrition, your activities, your medication adherence. And I think there's a tremendous amount of opportunity in that space. So just now going back to ambulatory care, no doubt that ambulatory and hospital care was dramatically catalyzed by the COVID environment. Prior to that, you saw Murray's slides about what proportion were doing the telehealth, so to speak, as the platform for care. During the COVID environment, one, many of our clinics had to shut down. We couldn't bring people in. Number two, many of our patients didn't want to come in. And yet the anxiety and the number of care situations exploded both in ambulatory and in hospital care. So what do? We leveraged many of the strategies that we had already had in place from online interactions, such as what we call e-visits. Now, by the way, e-visits is very akin to if you currently have a problem, many people will use Google to search, for that matter, not just health, but almost anything. You go to Google first or a online platform to try to figure out that answer. So for something like health, shouldn't that also be the solution that's available for our clients? So we created these e-visits, and we've actually had these e-visits, but we created rapidly COVID-related e-visits. And by the way, over the course of last year, over 5 million people took e-visits for COVID. Imagine if all those people couldn't come in or had come in, what complexities and challenges that would have faced. And yet we were able to do that online. And yet the online offering can't be the only thing that's available. Online has to be well integrated with a chat when necessary, asynchronous or synchronous chat, which then has to be integrated with a telephone call if necessary. And remember, telephones have been around for literally decades. It's nothing new, right? In fact, tele-shopping was available 3, 4, 5 decades ago. For those of you who remember the Sears and Roebuck catalogs, you used to look through the catalog and order things like that. But it took Amazon or similar platform to convert that and really transform that shopping experience. And so again, in healthcare, telephone's been around for years, but the coordination of the online experience to the telephone experience to the video experience is a critical integrated coordinated piece that then begins to create the virtual ecosystem of care. And that's what we've been working on. And again, if you go from each one of those should be progressive. So you don't start over again when you go from online to telephone to video. And then if you do need to take the inconvenience of coming in and seeing us, that should be coordinated already so that you're coming in only for the things that you need to come in for. And we're working on all of those things in our what we call the virtual ecosystem. And again, hopefully we get a chance to discuss a little bit more about the challenges as well as the benefits and some of the new ideas we have along those lines. And in the area of hospital care, COVID-19 overwhelmed every hospital in almost every region. In fact, Kaiser Permanente, certainly as a California-based system for a large part, was overwhelmed in our hospitals too. All of our beds, and in fact, many of our operating rooms and recovery rooms were also filled with COVID patients. And during that time, we thought, what if we were to leverage some of the things that we had been working on for delivery of hospital care at home and tailor it towards COVID treatment at home? So from oxygen monitoring to a delivery of medications in their homes to a platform that watched over them, so they were continuously being watched by our medical services. We created such a setting and in fact graduated over 18,000 people through that program, thereby creating not only a platform now for hospital care at home, but treating many of those patients during the COVID environment. And we'll be leveraging that platform going forward to, again, continue to expand the type of patients that can be treated at home instead of being treated in the hospital. Let's go to the next slide in the interest of time. If you think about where we are in the consumer space, though, we do have to be careful in that there is an explosion of point solutions for healthcare. And point solutions certainly provide for you ease and convenience, perhaps even at a lower cost. But if you think about health, it's a little bit different than banking or travel or consumers. Consumers generally know what they want when they go shopping. But in health, if you have a skin ailment, and then you have a joint ailment, and you have other ailments, they actually may be related in a sign of a more serious constitutional ailment. And yet, as an individual consumer, you would never know. So disaggregation of this care could be a negative, even though it seems more convenient on the surface. So that's an area that we really need to be careful. And right now, I think there's about $1 billion per week going into healthcare startups, and many, if not most, will fail. But in that milieu, we'll hopefully still be able to extract the aggregated, coordinated, integrated care that also provides for us better services at a better cost and higher quality. Next slide. And so we're looking at some of that. And in fact, if you look at millennials and Gen Z, who are really the generation that's really been growing up in the online setting, they have been unbundling their care. And we see this happening for convenience. And if you think about that disaggregation of care, especially given that millennials and sometimes Gen Z too, are less healthy at their age than the baby boomers, that could spell a problem for us in the United States. And therefore, making sure that all of these become integrated and coordinated so that healthcare prevention and underlying disease entities are not missed is going to be critical. So how does Kaiser Permanente try to do that? Like all other healthcare organizations, we were a very longitudinal type of care, right? What do I mean by longitudinal or linear type of care? You have an ailment, you go to the urgent care emergency room or primary care physician. Primary care physicians does everything they can. They take care of most things, but if not possible, goes on to specialty, and then so on and so on. And yet, if you think about this from a consumer viewpoint, no consumer said, what I want is an appointment, right? Or what I want is this. They're actually looking for resolution of their problem, not just the interaction with the doctor. That's just a venue for means to an end of them getting resolution of their care. So each visit that you have that didn't lead to resolution of care essentially was a waste for that consumer. So in this telehealth environment, shouldn't we be able to create a matrixed operation where whether you start online or on telephone or video or face-to-face, that we can truncate and bring forward the treatment or the definitive care, the diagnosis and definitive care in as few steps as possible. And that's what we're working on by leveraging the virtual ecosystem and in a way that's coordinated. So if you had e-visits in one time and you had a telephone visit with somebody else another time and a video visit or face-to-face another time, all of that is aggregated to make sure that there aren't any underlying problems that might have existed by doing a disaggregated care. So we believe that's going to be a critical part of maintaining quality in healthcare. Next slide, please. And just touching on chronic disease for a second, one of the chronic disease in the United States, of course, is heart disease. And there are approximately 1 million people who have a heart attack in the United States every year. And of those million, many will have a second heart attack that leads to death. And yet, if we could do an intervention for those people who've already demonstrated they've had a heart attack, you could save a significant significant number of lives by having the intervention. In fact, if that intervention was a pharmaceutical agent, it would be a blockbuster pill. But this particular intervention comes by way of cardiac rehab. And the traditional way of doing cardiac rehab was to have those patients who had acute myocardial infarction make an appointment to go to a facility to do rehab. And when they did that, many of them didn't make an appointment. It was inconvenient. They didn't have the time. They didn't have the transportation. They were holding down 2 or 3 jobs. They had care at home, et cetera, and many of them couldn't do it. So we thought, in this environment, what if we could reach into people's homes and, in fact, reach into that individual with a wearable, and having that wearable tell you the exercises that they can do, and that we would monitor their exercise through the wearables in a platform. Could we potentially improve that care? In fact, when we rolled this out, and now we've rolled this out throughout Southern California and quickly expanding to other regions, our completion rate more than doubled for people to complete their cardiac rehab. Patient satisfaction rates were some of the highest that we've seen for cardiac rehab. And during the COVID environment, when many of the facilities had to shut down, we could still continue to do the cardiac rehab because it was done remotely. We could send these wearable devices into people's homes so they could continue to have their rehab. And again, as we talked about earlier in chronic diseases, this rehab happens in their home where their families and friends see them doing it, where they can control their nutrition and medications and their behaviors. And the stickiness of the rehab they've done turns out to be significantly better. In so doing, the number needed to treat to save a life was 34, and we've graduated over 9,000 now. And you might imagine, if you do the math, way more than 200 people lives saved per year. And if you extrapolate that, this type of capability to the population within the United States of about 1 million people who have heart attacks every year, you could be saving literally 25,000 lives per year. So again, a tremendous opportunity in healthcare by leveraging telehealth and remote monitoring. Just a last slide to give you some advantage or insight in terms of the advantages of this. We talked a little bit about the completion rate, but the other interesting thing here is the bottom right-hand slide. Cardiac rehab used to be very, very used by, in general, the Caucasian population. They were, so to speak, the people that had easiest access to healthcare, and the number of Hispanic and Black Americans that were able to participate in it was disproportionately low. But if you provide the tools that they can do this in their own homes, at their own convenience, you can see the proportion that underwent cardiac rehab across the different demographics can be substantially more equal than a facility-based. So this is just one example, but we feel this type of care that brings care into people's homes in an easy and convenient manner that allows them to have health and healthcare in their own environments is a really meaningful transformation for healthcare in the United States. I look forward to a more robust discussion of all of these with you. Thank you, Murray. Back to you.
Thank you, Tad. Great presentation and a lot of fodder for thought there. So now I'll turn to our final distinguished speaker, Veenu Aulakh. Veenu is Senior Innovation Fellow at the Center for Care Innovations. She served as the organization's president from 2012 to 2020, and she has long focused on strengthening the health of underinvested communities and leveraging innovation and technologies to transform care. In prior roles, she worked as a senior program officer at the California Healthcare Foundation, managing investments in programs to improve access to care, improve health outcomes, and lower the cost of care. And more than a decade ago, she worked at Kaiser Permanente on care quality and patient engagement. Veenu, I'll turn it over to you.
Great, thanks, Murray, and really excited for this discussion and very excited to have this voice looking at the communities, underserved communities, which compared to what Tad shared, we're in a very different place. But to the next slide, what I wanted to do is give you a little bit of context. So as Murray mentioned, I was the president of the Center for Care Innovations for over 9 years. And we're a nonprofit organization really sparking, seeding, and spreading innovation to strengthen health and well-being of historically underinvested communities. And what that means is over the last 9 years, we've really been focusing on the organizations that care for underserved communities. So these are the federally qualified health centers, public hospitals, mental health centers. So in California alone, caring for more than 6 million patients, primarily on Medicaid and uninsured. So just at a high level on the next slide, and this was taken from a California Healthcare Foundation study. As you can see, the majority of populations cared for in federally qualified health centers are non-white populations, large Latino populations. And these folks are 95% of these patients are less than 200% of the federal poverty level. So what we're really talking about is really the low income Black and brown communities in California. So just to give you the context as I talk about the changes and the equity issues as it relates to telehealth, these are folks that look a little bit different from those served within Kaiser Permanente, for example. So the next slide. So as I may not have mentioned yet, but I've been working in the area of telehealth for 15 plus years. Previously, before I was at CCI, I was working on telehealth in the context of the California Healthcare Foundation. And pre-pandemic in the safety net, there was very little adoption. I know Richard talked a little bit about this. Primarily, most of the telehealth work was really in the specialty care access. In the safety net, it was almost zero in terms of primary care. And the biggest complexity back then was really reimbursement. Although there was interest, it just wasn't paid for. And as a result, there was very little done. And then the pandemic hit. And literally, I had been working on telehealth for 10 years, 15 years at that time. And in a week's time, the pivots were like amazing. People figured out how to hold up a telehealth program. And I think what's been exciting is the changes that we've seen in patient acceptance and private provider acceptance. People saying, oh, my patients, can't do that. They're not interested in telehealth. Providers saying, this is too complicated. And but it happened and it continues to happen. I think also during the pandemic, we have seen, limited evidence on what it means for quality of care and for health equity, and continue to be excited over the next year and coming years to have better data on that. And I think what we're excited about moving forward, and I think we're getting to that point now, is really starting to rethink what that model of care looks like. And Tad, I think, laid out some very exciting visions for that. I'm not sure, I think in the safety net, we're a little further behind. Our remote patient monitoring, for example, is just starting to happen. And I think starting to think about what those blended models and what that truly integrated model looks like. I think that's where we're starting to have some discussions. And I think there's a lot, there's still that question around the impact on quality and cost. And is this a substitute? Is this a supplement? I think some of those questions and trying to have better data around that. And then I think for us, really trying to identify where are those opportunities to address health equity that we haven't even figured out quite yet. So on the next slide, I wanted to share a little bit of data. So this is from a study or a program actually. So the Center for Care and Innovations runs a number of cohort-based initiatives. And this is one that we've been doing in partnership with the California Healthcare Foundation. It covers 23 safety net health centers in California, rural, urban, small, big, public hospitals. And as you can see, come April last year, we shifted tremendously, and telehealth visits were accounting for 53 to 75% of all total health center visits. And as you can also see, the vast majority of those were phone. So 94% of those have been phone, and only 6% were for video. And this is in the primary care setting. This is a little bit higher as we've been collecting this data on the behavioral health side. And on the behavioral health side, there is more video being done. Around 89% was still phone. But as you can see, a big shift. One thing that we haven't seen in our data, and I've seen similar data for Kaiser, is there wasn't a lot of variation by race, ethnicity, age, although there was a greater use for video for those where English is the preferred language. So still early in understanding the equity opportunities. I think the areas that we are seeing where it is a little more clear is where there are some inequities are for people where English isn't their first language. Obviously, broadband, rural issues have continued to be challenging. How to help support the elderly and homeless populations as well. So on the next slide, I did want to talk a minute about what we saw over the last few years. I think Richard pointed out, I think Kaiser was a much better position to make this pivot, but in the safety net, I think it's been a lot of challenges, both on the provider and staff buy-in, getting them up capabilities, people learning how to do tech support like they haven't, had to learn before, really figuring out those workflows, shifting team roles in a way that hadn't been prepared for things like that. I think also, especially in the safety net, figuring out how to support patients in using the technology. I think these issues around digital literacy have been clearly shown to be real. Not everyone is comfortable using a computer or has the capability to be able to do that. And such variation in the platforms that are being used and the complexity of actually being able to be able to use those to hook into video. I think the language barriers continue to be a challenge. Still, the interpreter, leveraging interpreters isn't seamless quite yet, and then continuing to have access to Wi-Fi and connected devices. I think this year's also been particularly challenging, obviously, with the pandemic, and on top of trying to shift everything to telehealth, there's been a lot of challenges in capacity, staff turnover, the ability to shift to focusing on vaccination. I mean, so all of that together have just made it, a lot more complicated. And then I think for, especially in the safety net, sustaining virtual care reimbursement, particularly phone, as I showed you those numbers. If we get rid of phone, we're getting rid of access for a lot of people. And there's still a lot of debate about what's going to happen still in California. And it looks very different in every state as it relates to phone coverage post-pandemic. So the next slide, please. So I think the other thing that for me has been particularly exciting about this shift and this sort of what's happened this year is I think there's a lot of preconceived notions about what underserved low-income patients want or are willing to be able to do as it relates to technology. And I think a lot of those notions have shifted. I think there's a big major acceptance of virtual care. It's very high. Although I think what's different about in the safety net is really that we do need to have these low tech options. And we can't, forget about the realities of, people living without broadband and not being able to use some of these platforms. And so I think there's, I think the other thing that we've realized is this need for new roles to help support patients who experience digital barriers. And people have been reshifting what a medical assistant does. And they've been bringing in volunteers and tech advocates and finding ways, if patients have a little more support, they really can engage in this way. So some really interesting things that we've been experiencing where people are literally driving to patients who are complex homes with video, then they're flipping a video visit to a provider in their clinic. So some really interesting innovations to address some of these equity issues. And then last slide, I mean, I think that's some of the areas that I think that are also very interesting for the future. I think one of the exciting changes we've seen is in behavioral health and the rapid adoption of video and telehealth in behavioral health, both to improve access points. We've seen huge reductions in no-show rates, reducing stigma and sort of equalizing it. I think the other opportunities are a lot of what Tad mentioned is like, okay, let's start talking about virtual care beyond just video, but how do AI and chatbots and texting and, other remote patient monitoring. I think we're just early on in the safety net to start thinking about that model. And how, there's been populations who haven't come in for care before, and video and telehealth and virtual care in general opens up some opportunities for people, migrant workers, homeless populations, folks who it's been challenging, some of the complex, frail populations. How could we reach them in their homes? And then I think for me personally, as someone who's been focusing on innovation and thinking about, here's an opportunity now to really rethink care delivery models. And let's not just substitute one for the other, but like, what does the model look like moving forward, where we can think about one clinic that we're working in is bringing in new patients into the visit. Now that it's on video, you can bring your clergy person and your grandkids in, and you really have a different kind of visit because you have people engaging in a different way. So super excited to have the next discussion, and I wanted to thank you all for including this important voice of the underserved into the discussion.
Thank you, Veenu. The hardest part of my day is getting that mute button clicked off. So I want to welcome all of our speakers back onto the main stage. And as we're doing this, I'll just remind folks in the audience to submit questions in the Ask Question box, which again should either be on the bottom of your screen or off to the right, depending on what kind of device. I'm not the first to say this, but all of you touched on something that we've heard frequently in the past, year, 6 months, is that we made more progress in 10 months on telehealth than we had in the previous 10 years. And I think building on that, I'll just ask a real open-ended question. What are you optimistic about for positive developments in the telehealth space in the next, let's say, 5 to 10 years? Are there situations where telehealth can be particularly valuable? And then we saw the video with what at least one set of patients is demanding from this. And how can we better meet what they're asking for? Richard, can I pick on you?
Absolutely. Thank you. I think, one of the lessons I think we all learned is that the horse is out of the barn, as they say. I think people recognize that telehealth has the opportunity to have a real impact. And I think also it exposed a lot of vulnerabilities of organizations that weren't ready. Kaiser's kind of unique in that you were ready and you just basically ramped up what you're already doing well. I think the remainder of the population and the healthcare systems were trying to figure out how can they make the transition from the traditional way of pay to the more advanced virtual care. The key to that is going to be alignment of incentives. Providers and patients both need to be aligned to working in this new integrated world. And I think that's going to be the challenge, is how can we establish policies and procedures and reimbursement that's going to incentivize innovation. We can come up with all kinds of great ideas. A lot of the ideas that we used last year were invented 25 years ago. I used them in the Navy. I didn't have the advanced technology in those days, but the reality is that it was available. It just wasn't incentivized. And I think that's going to be the key.
Certainly a big part of it. Ted?
Yeah, I think there's nothing like crisis to really point out your needs. And I think what the COVID environment did for us is, as Richard has said, the underlying platform and technologies were there. the strategies and concepts were also in place for many programs. But at the end of the day, innovations, like any diffusion of innovation, is challenged by the change management piece, or patient and provider acceptance piece. And what COVID did was essentially grease that particular challenge, right? So from a patient viewpoint, they didn't really want to come into the medical office buildings. And then from the provider viewpoint, to be totally frank, Richard, you and I are probably much more comfortable at our stage in our careers of continuing to practice the way we always practiced, because we gain certain skill sets when patients are in front of us. And we're a bit reluctant to change that, because in healthcare, small changes can have consequences that are unintended. And as a physician, you do not want to miss anything. And by having the patient in front of you, you have that comfort of experience, so to speak, to make sure that you're doing the best care you can. And yet, when patients are now coming to you online or on telephone or video, you're afraid you're going to miss that. But what you've actually done is opened up your availability to a much wider group of patients. So in actuality, as a population, you're probably providing more and better care because more people are able to see you. And yet, as an individual, that sense of discomfort kept us from going holistically in. And through the COVID environment, it taught us, even orthopedic surgeons, right, can actually do telephone visits and video visits. And really now the next step, Marie, is really about figuring out which venue of care is most appropriate, balancing the convenience and the quality, right? The cost and the comfort, all of those things, to make sure that that particular type of care, not just in terms of specialties, but specific ailment that you're having, is most effectively cared for by that particular platform, right? So that whether you need to just hear what's going on, or you need to see what's going on, or you need to touch to try to figure out what's going on, and each of those are slightly different platforms. I think the challenge is going to be to fine-tune it so that we provide the maximum, so to speak, quality of care at the maximum convenience. I think it's going to be a very fun, in fact, for those of us who've been in practice for 20, 30 years doing the same thing, I think the next 5 years is going to be incredibly challenging and exciting as we really begin, as Veenu talked about earlier, about how we change so to speak, the re-engineer the way we provide care. So yeah, looking forward to that very much and seeing what we end up.
Yeah, the challenging time is, when you have a foot in each canoe, so to speak, and you got to make the decision. So, what are you most optimistic about?
There's so much. I have been working in telehealth for so long, and I've always seen the possibilities. And now I feel like a lot of other people see the possibilities and opportunities. For me, there's a number of things. One is, I think for a lot of the underserved communities that we work with, their lives are so chaotic, and, getting to a healthcare visit requires taking time off from work, taking 2 buses, paying for all of that. And all of a sudden you're able to shift that to make it work for people's lives. Migrant farmers and folks who really just weren't getting the care can now, take 15 minutes to have that phone visit. So I think, one of the things that I'm excited about is thinking about opportunities to reach people that we haven't been able to reach in the past and what that looks like. And I think also in terms of behavioral health, I'm really excited about the opportunities there and addressing some of the stigma. And especially after this year, the behavioral health needs are so significant, and knowing that there's ways to address that. I'm also excited about the coordination possibilities. I think we've been thinking about how do you actually effectively integrate behavioral health and primary care with not enough of the workforce to do so, where you may have a behavioral health person at one clinic, but not the other. And now via Zoom platforms, you're able to bring people into visits in a way that we haven't been able to do before. So in some ways, we can leverage workforce in interesting, meaningful ways to serve the needs. And I'm also really excited. A lot of the things that Tad had talked about, like things that seem so futuristic, for so long, it feels like we're now at a place where we have provider acceptance, we have patient acceptance, we have the tools in place, the if the reimbursement sticks and stays, like it feels like over the next few years, there's some really exciting synergies to make some of these ideas that, as both Richard and Tad said, aren't new, but now we can actually get them to be real. So yeah, that's what I'm excited about.
Great. Veenu, you raise an important issue too about people with complicated lives and the time challenges. I remember being part of a role-playing exercise, I don't know, about 10 years ago, and it turned out that the hardest thing was getting everything you had to get done in a week when you were, as you say, taking 2 buses and not able to fit things around your job, but had to be at the job at a certain time. So certainly the digital world can help there if we can get the technology to people. I was trying to think how to frame this question. We've seen such advances over the past 15 years in the digital world in general, and all the things you can do that you couldn't do 15 years ago, whether you're ordering a shared ride, whether you're booking a restaurant appointment, whether you're doing your banking. And we're doing things now that I don't think many people even particularly envisioned in, say, 2005. So it's been a very distributed model of innovation, and people out there think up good things and make them happen. And Tad, you raised the issue of how do you maintain coordination and integration. Richard, I think you raised this as well. So how do we leverage, if you will, the benefits of distributed innovating while still maintaining a focus on the whole person? Any thoughts?
Well, Mary, open, I guess, a comment here. One of the things when we work with our clients, one of the things we look at is we don't start with, what is the technology they're looking for. We kind of learn what are you trying to accomplish? What are you doing today, and how can you do it better? And then we look at what the future might look like and decide what, if we worked as a team, and we may want to introduce, in fact, I think, Ted, you mentioned it, and maybe Veenu as well, that you may want to introduce new roles. You may want to add new roles to support things that hadn't been done before. So, for example, a virtual urgent care clinic, you may have to have a call center to support those people who don't have the technology or the wherewithal to do it. So I think the key is understanding where you want, what the target is, and re-engineer it, not just simply add new technology, but re-engineer the process. And it requires a workflow, it requires support, and it requires the integration of systems to be able to provide that new way of doing things. I think the example of the cardiac rehab is a fantastic one, because that really shows, you have to integrate information over longitudinally, not just in a single episode of care, which is what we've focused on pre-COVID. Now we're looking at people over time, and now we can align financial reimbursement, is going to incentivize that better outcome, not just simply the number of services that you offer.
Yeah, Richard, I think you raised a really good point. It's refreshing to hear you looking at it from an enterprise or systems viewpoint. I think the systems viewpoint is really critical. And Murray, I might even turn that question back to you a little bit too, in that when you have people like Richard that are thinking about it from a systems viewpoint, I think we're going to be able to protect that integration. But if you then turn around and look at, so to speak, the investments that are happening with point solutions that are more technology-led solutions to problems rather than solutions to problems that we need to solve, right? And Richard said it better than I did. And when you do that, one of the things that can happen is that people begin to pick at the solutions that they think they need because it's convenient. And in so doing can lead to disaggregation of the care that they need. And again, it's a fine line between healthcare and other things like, for your banking or going to a restaurant for your travel. Consumers know what they want, and they can coordinate their schedules in the way that they think is best for them. In healthcare, it does require a second layer of knowledge to make sure that a few of the ailments that they have are not symptoms of a serious underlying disease. And in order to do that, coordination and oversight, so to speak, of the care that they're getting is really critical. So the reason I might turn this question back to you, Murray, is that as we really begin to look at the policies and regulations around how these companies are set up, what are some of the type of influences that we can have to make sure that the quality isn't deteriorated by creating an a la carte healthcare system, and that even the a la carte providers are somehow responsible to make sure that there is some centralized coordination of the care for that particular patient that they're serving?
Well, I'm not sure I have the answer to that, but I have the start of the answer to that, which is measurement. And we have to know what it is we're trying to monitor, which frankly we don't do a particularly good job of today. I think about data a lot, and we have data on what happened. What we lack are data on what didn't happen. And this is especially important when you're thinking about equity. So we can look at advancements in care and improvements for a well-off insured population, and it's a much bigger challenge if we're looking at people who are uninsured, people who may be distrustful of the healthcare system. Ted, you said patients know what they want. That I agree with that. In fact, I would always presume that. I'm not sure they're always able to articulate what they want, and whether it's something as quote unquote simple as a language barrier, or just I can tell you that my knee hurts, but I can't tell you that my real problem is I'm depressed. There's challenges there, and so I would like to be thinking about a system that is moving towards trying to monitor the health of people and populations, and not just solving things, sort of the micro care, if you will. A lot of questions coming in on different topics, so let me try and turn to one of those. Question is, and I'll throw this out to anyone on the panel, but Veenu, maybe start with you. Can you talk about strategies and how to help patients become more comfortable with telemedicine, telehealth, and anything specific for the elderly population who may not be as used to it in the rest of their lives?
Yeah, it's a good question, and something we've been spending a lot of time in our clinics looking at. I mean, one of the things that a number of organizations have introduced is this digital equity intake form. So when you're starting to basically check in a patient, also assessing their digital literacy capabilities and their preferences, and not making assumptions about what kind of visit works best. And then I think, what we're seeing a lot with the elderly is just having a little extra support. So having someone, we've been, a number of organizations, number of our clinics have been using volunteers or pre-med students who just call the day before and see if someone's comfortable, how to help them answer questions around Zoom or Doxy or whatever the platform is, so that they're comfortable. And then making sure that after the visit, you're also following up and that they're clear and they've captured what they need. So in some ways, especially what we've been seeing with elderly is not necessarily more technology, but just supported technology and being able to, address what questions they have.
Yeah. Mary, I would comment as well, based on personal experience, seniors will do things for their family that they won't do for themselves. And so oftentimes, if a son or a daughter would ask a parent to do something, they'll often do it. And so one of the things that technology offers is the ability to have multi-point conversations. You can bring in family members and you get much better engagement. And I think the key with seniors is that they need to know what to know, they need to know why they're doing it, and then they need a family member to motivate them to do it. And I think if we were to take advantage of the capabilities, it gets back to re-engineering. How do we do things better, not necessarily the same? And I think that's one of the things when you're dealing with seniors or children, for that matter, the same thing, is you want to bring in other family members to help support them if they're available.
Yeah, I think it's a really critical point. That's so true too. For people's health, it's their social and family network that is probably more meaningful for them than the individual motivations. One other thing that I think is important to do, Marie, is to really learn from the leaders in digital enterprise. And if you really look at what Amazon and other people who have done this really well, is they look at human-centered design. They actually look to see what type of interfaces patients or consumers are naturally comfortable with, and they make small changes continually to improve the interface and the effectiveness of that interface. And one of the things that we've been working on are, one, a multitude of patient surveys, interviews, as well as just watching how people interact with our e-visits and our different online type things. And just by watching what they typically do or where they get confused, or sometimes having them walk through it while they talk through it. They're saying, I'm going to click this because I'm not sure what to do next. And you listen to all of that, and it is tremendous insights in terms of how people typically interact online. Those are things that I think as physicians we've typically learned. We read their body language, right? We read their voice, we read their eyes to try to understand that they're maybe getting at something that they're not saying in words. And we have to find the equivalent of that online. And human-centered design is going to be a critical element in terms of doing that. In fact, in some ways, we may be able to do that more consistently online because humans are very, very interesting. They behave in certain ways based on their emotional state. Their voice and their facial expressions are very expressed based on their emotional state. And depending on the human that's receiving it, we may or may not be as sensitive on it. But with the appropriate training of machines can actually be quite consistent in doing that too. So not to sound like we should have Mr. Roboto be the doctor for everybody, but there are some advantages by leveraging human-centered design and machine capabilities to improve that. And I think that's an area that will continue to evolve over the course of the next decade or so.
You know, Ted, to that point, I think one of the things that's real important is the consistency across these different service lines. One of the challenges we've had in the past is you have an app store of multiple applications that do things differently. And that's hard on the providers, it's harder on the patients. Whereas if you have a single platform that allows you to do things just like Amazon does for retail, in healthcare, if we have one way of doing things, people will be consistent and reliable and they predict where things are going to be, they're more likely to adopt it.
Yeah, just one thing to add to that. It's interesting. A couple of our clinics have actually, as they've been trying to figure out the right platform, they've been including patients in the selection process so that they're really giving the input in, and it's not just driven by providers as well, which I think is an interesting idea.
Yeah, arguably this patient-centeredness is a revolution in healthcare writ large. We're getting a number of questions. We got some submitted earlier and then some today that are getting at this. Does telehealth substitute for in-person care, or does it supplement? And pretty clearly in we saw several charts here that said in the midst of the pandemic, it was a substitute. And Ted, maybe I'll start with you, because I know sort of back in the day when we've tried to measure this, it's been a challenging question to kind of answer. And maybe you could just go into what those challenges are.
Yeah, I actually don't think it's a substitute, but a complement or supplement. I think much like, I'm going to just use this old analogy again, you know, the Sears and Roebuck catalog where you could order everything and you could just pick up the phone and order it. Well, it was popular, but it certainly didn't revolutionize retail, did it? And it's because it was a single platform that was just for that, right? It was convenient for certain people, but not so to speak, available for everybody. What the new digital transformation does, what Amazon and others do, is that they have the entire ecosystem of that purchasing available, right? So from purchasing to payment to returns to delivery, they have it entirely worked out. And I think the key now in healthcare is to try to figure out which one of those venues or which one of those type of interactions is most appropriate for the problem you're trying to solve, rather than forcing a patient to say, for you, it's going to be a telephone visit. It should be that we customize the interaction, and some of them will remain face-to-face. Others will be telephone. Others are better online. And every individual will be a little bit different. And the challenge of this is to try to fit the appropriate venue, including the type of ailment they have accurately, so we don't decrease the quality, and yet we improve the convenience so that they're more likely to access the need that they have, right? And I think some of that is going to be just empiric and experimental, and over the course of time, through experience, we'll learn which one is best. And I think we're still at the very early stages of that, and I would be remiss to tell you I know the answer to that at this point, Murray.
And Ted, to follow up on that, one of the lessons learned from the Navy is submarines have very low bandwidth. And so we didn't have the option of real-time video. We had baud, not kilobaud or megabaud. And so we had to use basically store and forward more appropriately. And so I think it's not only just the question of what technology, you have to think about what's appropriate technology for the scenario. If a decision isn't imminent, you don't necessarily have to have it in real time. That's not very efficient for providers. It's not efficient for patients. And so having the ability and luxury of multiple avenues, just like in radiology, you have multiple modalities to choose from. We have to have a virtual care environment where we can provide multiple approaches to solving problems, where patients and providers can pick the appropriate technology and approach.
Yeah, we've had several questions, or maybe more statements, expressing concern that patients will view themselves as, some patients will view themselves as being denied access to an in-person visit when they're actually just being offered telehealth. Veenu, do you see this? Well, actually, Veenu, I think I want to ask you a slightly different question. So as Tad was talking about Amazon, which is where my life savings goes into, that solves a problem for a whole lot of people, and it solves no problem for another whole lot of people. And how do we do the Amazon thing for the safety net clinics and for the patients they serve?
And when you mean the Amazon thing, you mean the
digital divide? The digital divide, I guess, is what we're referring to.
Yeah.
Yeah, I mean, I think the digital divide doesn't have to be a divide if we take care of a few things. So I think, having a supported digital experience, I think, can be helpful. One, thinking about how to simplify. So, I think Amazon's done a great job of creating a platform that's simple enough to use, that doesn't require a lot, but honestly, a lot of video platforms that our clinics are using are far from simple and require multiple logins, and then you have to have an email address, and the barriers that are put in front of them right now do not make that an experience that's going to work for them. I also think having, if we're comparing to Amazon, if there was, digital, I guess, geek squad for the safety net, where you can actually, for some people, you may need to go out to people's homes and help them get started for the first time, and having that ability where you could have a little more high touch, so that for the long run that they can really engage, and that there isn't a divide there either. And then I think not being very cognizant of where the other barriers are around language, and making sure we're far from figuring out the interpreter issue on most platforms. So how do we make sure language is dealt with? How do we make sure, that there's options for people if they don't have broadband, how that we have phones. So I think it's really the options, the simplification, the adding a high touch option. So I do think we can get there. It just is going to require more cognizance about coming up with the solutions to solve those problems.
Thank you. And I'll just add that we've had a couple questions in the chat about including American Sign Language as part of language challenges here.
Yes.
We're coming up on time, so I'm going to do just a 30-second lightning round in the order in which you spoke. So starting with you, Richard, what's the one thing you want to leave our audience with, our audience today and that future audience who log into the recording?
Well, I think in the past, prior to COVID, telehealth was innovated at the middle level of the organization, the departmental levels. I think now with COVID and the exposure at the senior levels of organizations and enterprises, they recognize the importance and opportunity here. And I think that's going to make things a lot different, because new resources will become available, and new incentives and new accountability will be available going forward.
Great, thank you. Tad?
Yeah, thanks, Murray. I would say that for all of the audience, from policymakers to payers to providers, it's time to embrace the transformation. I think there's a tendency in the healthcare to want to stick with what we know, what's been proven. And I think there's a great deal of benefit in doing that. But in this time of transformation, if we don't embrace it, much like the others that were left behind in the digital transformation in the consumer space, we too could get left behind. So let's not do that. Let's make sure we continue to do the best we can for our patients in our society by embracing the tools that are now available for us to really transform healthcare and bring it to a level of care and quality that we could only dream of in the past. So look forward to working with all of you guys and seeing a bright future of healthcare.
Thanks, Ted. Veenu?
Yeah, and I love that framing around embracing the transformation. I am excited and very hopeful that we're not going to go backwards. I think from a policy perspective, seeing that this is work, that this has meaning and can make improve. I think this is the big innovation of taking healthcare to the next level. And now it's our time to improve and refine, but we know that this model can work. And using this time also to rethink our models that we had talked about. Let's not just assume what we've been doing has been working, but let's really think about what that true model that meets patients' needs, whoever they are, wherever they are, can be met.
Great, wonderful. Well, I want to thank the panelists for sharing their time and their insights with us. I learned something every time we do one of these, and I've learned a lot again today. And yeah, it's a big issue. For our audience members, we will email you with a link to the recording that should go up in the next couple of weeks. And thank you for joining us today. And take care, everyone. Bye now.